And with that, I will welcome our next speaker, Dr. April O, who will be facilitating our last session of the day. April is Program Director in the Health Communication and Informatics Research Branch for the Behavioral Research Program at the National Cancer Institute, Division of Cancer Control and Population Studies of the National Institutes of Health. Welcome.
Hi, everyone. Last session of the day. Thank you so much, Roundtable, for inviting me. Thank you for introducing me. So we're going to conclude this workshop together after 3 really interesting sessions where we've learned about what the problem is, and we're going to be moving towards now talking about how to advance effective communications towards obesity solutions. It's a time for us to reflect on the day's discussions, identify themes that we've heard today, and then also future direction. So I have one ask of all of you, which is while I've been asked to give my reflections on the day, while I'm reflecting, I want you to think about a key reflection or takeaway that you've had, and then bring that into a question for our panel when I invite everyone up. And we're going to spend some time in an engaging discussion. Would love for everyone to be a part of that. So, the big green button. It's always the big green button. I have no financial conflicts to disclose, and the views are my own, and they do not represent the views of my employer. So you know what the sessions were about here, but I thought I'd highlight them here again. So you know what the key goals, just as a reflection and reminder of what we had been talking about today. As we move into session 4, I want us to think about that frame of going from the problem to the solution. And as I was doing that myself and reflecting on what I would want to share with all of you, I thought of 4 key points. So first, after hearing all of the great conversations that we've had today, there's some key assumptions that are traditional in obesity-related research and health behaviors research that we really have to tackle as we're thinking about moving forward. First, the traditional assumption is that communication and messages are static. And we heard this morning from Adelaide that in fact is not the case. In fact, every second we have 6,000 tweets. And then if we think about it even more, over the course of a year, there's 200 billion tweets in a year. And you can imagine now we live in an environment where one tweet can actually change federal policy and even international policy. So one word, one tweet, those characters have a big voice and impact, and it's constantly changing. We're in a 24-hour news cycle where one thing that was relevant one day is no longer the next. Second, it's been stated over and over, obesity is not a choice. And as members of the Roundtable, you're very attuned to that. It is not a moral failing. Obesity is a chronic disease, and we're living in obesogenic environments. So, of course, we have an obesity epidemic. Third, our message is not the best message or the only message that is out there. We have to keep in mind that health is not everyone's top priority. It's not everyone's top goal and value. People want to take care of their families. They want to be happy. They want to find love. So we're matching goals for being healthy with other messages that may be in the environment about social acceptance. If you buy or eat a certain product, it's really hard to compete against those messages. It's science. People will trust it. Oh, if only. I would love that. But actually, that's not necessarily the case. We know that there's this diminishing trust in government and institutions. Evidence is not enough for dissemination. And people already know what they should be doing. Telling them what to do does not create change, and we've heard that over again today. So that leads to knowledge is not enough to actually change our behaviors. People already know what they should be doing. So the other point that we've heard over again is around communities. We have different audiences, different communities, and different patients. These are not homogeneous. And when we ignore all of these different assumptions, we're actually creating barriers in our efforts to reach the potential impact of our evidence-based messages. Second, addressing communication inequalities. Disparities have come up a couple of different times, and inequalities have come up from the first session, and now I'm hoping we can bring them up today and as we talk in our discussion. We know that there are certain population groups that are affected more by obesity than other population groups. When we're developing our messages, are we leaving certain groups behind? Are we exacerbating disparities? Racism, discrimination, disparities in income, education, and health literacy, neighborhood environments, including targeted junk food advertising to children, teens, and communities of color with the least healthiest products, digital media marketing to children who have limited health and digital literacy and also have not quite developed their frontal lobe. They experience and observe discrimination bias. There's also bias in the healthcare setting and stigma by race, religion, sexual orientation, and weight status. There's lack of healthy and culturally acceptable foods, neighborhoods with lack of safety and violence. We all know all of these things. But all of these things aren't just words and things that we study. They contribute to the inequitable distribution of information. They contribute to inequitable access, inequitable distribution of information channels, and also relevancy of that information once someone receives it, so that they have the capacity to actually act on that information. And it's also possible that even if they get that information, they actually don't have the resources to act upon it. So then, in that case, we're exacerbating the disparities. So we've heard a couple of times today, and Brian Southwell also mentioned this quite eloquently earlier in his remarks, that our communications are embedded in a broader systems of interactions, multiple systems that are interacting together. And to address these inequalities that I just described, we need cross-sector partnerships. We've talked about that before in other meetings and other workshops. How do we actually do that and embed that within our communication messaging? One that we've heard in the third panel is that the different audiences, whether they're policymakers or people who are trying to lose weight, there's different messages that are salient to them. We have to think about the audience, but also that these messages interact across levels and across systems. It's not just that one message reaches one audience in isolation. They're fluid. Our systems are dynamic. We have to think about the different channels. What works for one audience group does not necessarily work for another. We've heard that with the VERB campaign. Also, we have to talk about stickiness of messages across these different levels. Engagement, action, social media campaigns, eliciting and starting to encourage behavior change, identifying tools so that someone can make behavior changes. Those are important parts of engagement. And also thinking about influence. Influence is incredibly important as we're thinking about who are the trusted leaders within all of these different levels, and how are we making strategic partnerships to make that happen. So I promise I didn't talk to Luis before, but one of the pieces that we have found that has been incredibly interesting in some of the portfolio that we've been funding at the National Cancer Institute is thinking about co-creation and co-design. So I don't want to go into a lot of time in terms of describing what that is. You've heard that really eloquently from Luis. But what is really nice about thinking about co-design when we're thinking about addressing communication inequalities is you're bringing in the communities themselves and developing those messages so that the goals and values are reflected. But what if we were to think about co-design not just with communities, but also with partners as part of that process? What if we were to start to bring in industry representatives as part of that co-design process? Is there a possibility that together we can come up with what that problem is for which we're trying to develop a solution for? The other piece that I really like about co-design is that, again, we are in a 24-hour news cycle. There's so many different channels. We're getting a lot of information. And people's behavior, societies, and systems are dynamic. So what's nice about co-design is that you can iterate on messages. And we can't wait, because messages are continually entering into the environment. So we have to be more agile. And agile thinking allows us to be a bit more pragmatic and a little bit more responsive to what may be happening in real time. The other power of community-driven co-design, as we're thinking about disparities and inequalities, is that it allows for empowerment, generation of trust, and maybe even we're developing new social influencers as part of that process. The fourth point that I want to make is a little bit different from what we might have heard earlier. I'd like for everyone in the room, as we're thinking about solutions and what might be that next place where we move forward, is to think about implementation and dissemination. How are they similar and how are they different? So in this graphic, what I have is sort of this pipeline. We have diffusion, which is a passive, unplanned, untargeted spread of information. You may be familiar with some of these images. These are traditional public health campaigns. And here with diffusion, we are letting the information happen. We're putting it out there. We're not worried about the action. We're just putting it out there and it will spread. With dissemination, this is targeted distribution of information and intervention materials to a specific audience. And I think that we've heard a bit about how to do some of that dissemination work for certain types of communities and certain individuals. And that's where we're trying to help the information happen. We're trying to help and encourage that behavior change. We're trying to help and encourage that systems change that we want. But with implementation, this is where we are making it happen. This is more activated. What we're doing in implementation is we're trying to understand what are the strategies to get what we know adopted and integrated into policy, practice, change in community environments. And that's where I would like us to potentially think about for the future. Because a lot of what we've heard today, especially in session 3, there were some great interventions, some great communications lessons learned that I think that many people could benefit from. And it can inform our future thinking as we develop more evidence-based campaigns, messages, and interventions. Because if we don't think about implementation, say we take any of the programs that we discussed today, its impact on population health will only be so good as to, number one, is it adopted by another community? Are providers trained to deliver it? And are trained providers, once they are trained, do they choose to deliver it? Sometimes they don't have time to. And then finally, are people who are eligible to receive the program, are they going to receive it? If we assume a 50% threshold at each of these steps, even with perfect access, adherence, dosage, and maintenance, our potential impact would be only 6%. And I think that we can do a lot better than that, right? So implementation is more than efficacy and effectiveness. This is an example of the RIA model, which is reach, effectiveness, adoption, implementation, and maintenance. And I provide this model because I wanted us to just kind of get familiar with some of the questions we can think about as we're thinking about implementation of our solutions. So one is reach. How do I reach the targeted population? And am I reaching the right population? Are there populations that I'm leaving behind? Effectiveness. How do I know that my intervention is effective once I have it in one community and I bring it to another community in another state or in another population? What are the measures that I'm using to make sure that it continues to have the impact that we want? Adoption. How do I develop the institutional support to deliver this campaign, this intervention, this message? What pieces of it have to be adopted to match the population's goals and values? Implementation, how do I ensure that the intervention's actually delivered properly? And then finally, after all of this, we hope that we have the effects maintained over time. And so that's where we would look at maintenance. So I'd like for everyone to challenge ourselves to think about what our end goal and solution is, what it looks like, and how we're going to make progress to get to that. One way is, as we're thinking about that and making the steps towards that progress, is thinking about implementation. What are the key pieces that I know work, and how do I get it into practice or into the environment? So, with that, I would like to invite our panel to come up, please, and join me up here, and then we can begin our discussion. So, thank you. All right.